So we've been profitable since 2004. We also have a number of different products that we leverage the core in order to get a higher margin, break even on connectivity, and add additional products and services on top of it. In our journey, we really didn't go for grants until ARA came out, and most grants were not along the path of where we were heading as far as our business plan goes. But with the advent of ARA and some of the products or some of the priorities of ONC were dead in our path of where we were going. And so we've gone from a non-grant entity to using, we're an REC for our region. We participated in the next phase after Med Virginia in the SSA program and CHIE with IBM. We're also a beacon site. And all these we are viewing as capital for the next phase of development. We've already got eligibility, electronic lab ordering. We support PCMH. We have registries. But we're using beacon dollars, similar to other communities, in order to take the infrastructure to a different level that will then allow us to do, instead of light analytics, do full analytics. So we're taking advantage of all the great programs that ONC has out there, and we really view that as our value proposition going forward, because with Indirect, which we're also participating in, as well as other just general transport of data, that piece is going down, and the value long-term is in supporting other community initiatives that are addressing the triple aim. So in our beacon work, we're very focused on we're very focused on asthma and diabetes, but we're really looking at that infrastructure once we move the dial, that we move it towards an ACO kind of environment where competitive ACOs can be on one platform, but it dramatically reduces the cost of participating in an ACO by having one analytics package, and as Claudia said, have the folks looking around the table and having folks in different regions around the table, but using the same infrastructure in order to have a higher quality product. Kate?
Thank you, Keith. And last but not least, Ted Creamer from Rochester. Are you with us? I know you had some technical difficulties, but I think you're with us now.
Yes, I am, Kate. Thank you very much.
Wonderful.
So we were, my name is Ted Creamer. I'm the executive director of the Rochester Rio. We were established as a nonprofit, as sort of a part of several regional care improvement efforts in 2006. And our mission was really to create a framework where patient information would really follow the patient. To that extent, we cover some 1.3 million patients across a 13-county area in Rochester and the Finger Lakes region of western New York. We currently provide sort of two fundamental service venues, if you will. We provide a results delivery and a patient-centric query service to almost 4,000 users across 400 organizations. The data is coming from some 70-plus organizations. On the results delivery side, we're currently supporting about 140 physician practices who are using one of 14 different electronic health record systems, so we're very similar to the direct model. On the query side of our business, we've done a good bit of patient outreach, communication, marketing to patients, consumers. So we've seen close to 500,000 patients consenting to their care providers to allow them to access the information through our Rio, because those query services do need consent for us. That consent rate, that positive consent rate, tends to hover around 97 to 98% of the patients say yes when their physicians ask them. In addition to the kind of traditional HIE data sources of hospital reports, transcribed reports, lab information, we also include radiology reports, radiology images as well, so we have a pretty robust radiology image exchange, medication information. But we also include somewhat less traditional care information because, again, we're trying to move to this very care-focused model. So we also include social service-based information for based on elder care information, and EMS information from our EMS providers. The other piece we've been moving on is providing consumer connectivity. That was something we heard early on, even when we started up. So we already provide consumer connectivity for patients to at least let them manage their consents, request audits online. They can also share advanced directives with their providers through our patient portal. And starting this summer, we'll be supporting two-way connectivity with personal health records. When we've built our business model, it's really based on funding from sort of two streams. There's funding from health plans, employers, and hospitals. But basically, 2/3 of the funding is coming from the employers and the health plans, and 1/3 of the funding is coming from the hospitals. And somewhat related to what Claudia was talking about, the funding and all of our sustainability was really predicated on meeting a series of very discrete performance benchmarks and providing our customers really specific dashboards demonstrating our operational transaction query volumes. So we really had to provide those sort of dashboards back to our customers. And what we end up doing is sort of setting our fees each year from those two different, employers and health plans and hospitals. But we set the fees just to sort of cover our operating expenses each year as a nonprofit. Works well for us. Moving forward, I think what we will see is a lot more patient connectivity. I think we've heard that everyone is looking at the analytical side of things. But with that, I think there'll be more conversations, Kate, where we all talk about what our futures will be. So that's sort of a snapshot of where we are today.
Thank you so much. And I think what we found is that we have a very diverse group of organizations that started in many different ways, but in some ways are evolving in the same direction ultimately, which is an interesting trend. So I'm going to throw out a discussion question or two and call on a few, but I'm also going to suggest that if any of our HIE leaders or colleagues in the room have pressing questions, we may have a chance to, go with one of yours as well. So I'm going to start with a theme. I know from our findings that a lot of you, I'd like to have a couple of you comment on your strategies related to consumer engagement. And I think, we've heard there's a wide range of approaches being taken, but I know this is something that's near and dear to the hearts of the NEHC board and certainly is a very important priority for ONC as well as many others across the country. So I guess I'm going to pick on Tom, since you haven't had to talk for a while.
Thanks, Kate. Consumer engagement's been a very important issue from us since the beginning, and I originally started with creating what we called the Inland Northwest Community Health Information Board, where we brought all of our key providers together and partners, as well as consumers, educators, health plans, pharmacies, a number of other parties, to really help drive with physicians kind of what was important at the point of care. Today we offer such things as, personal health records. We're doing a demonstration for the state of Washington on that. We are trying a lot of different ways to do things. We're even looking with mental health consumers about using phone applications for reminders on taking their medications and things that seem rather simple, but they're very, very important from a consumer perspective. We continue to convene consumer groups and solicit input to really try to make our system user-friendly and also meaningful to consumers. Clearly, having consumers at the table, I think, has been very, very important for us from the beginning, and I think you'll continue to see us very, very committed to bring the best thing that we can, really, from consumers and from their perspective, and especially with different consumer groups. We're definitely interested in the underserved consumer groups, and we also support a lot of community hospitals that are out in rural areas, so we're the lifeline for a lot of communities. We use telemedicine as well. We allow consumers and others to use that system, and we do a lot of things that really serve as a lifeline using technology as a way to really build that bridge.